Okay, good day. We are the Group 5. In behalf of my group mates, I would like to introduce to you our topic, which is all about hemodynamic disorders. Okay, so when we talk about hemodynamic disorders, the main organ and tissue that is involved are blood and vasculature. And as we all know, blood is the medium for the transport of nutrients that our body needs, and as well as the transport of waste products. Okay, well, blood can also be affected by various physiological changes that may lead to these hemodynamic disorders. So there are several disorders that may lead to impairment of the vasculature and the circulation of the blood, namely hyperemia and congestion, hemostasis and thrombosis, embolism and infarction, edema and shock. So first, let's have the hyperemia and congestion.
Hyperemia. Hyperemia is defined as a sudden increase of blood volume in the blood vessel. Hyperemia has two types, active hyperemia and passive hyperemia. Active hyperemia is observed from the arterial dilation, while passive hyperemia is observed from venous return. So active hyperemia. Active hyperemia is observed from the increased blood volume in an arterial dilation. All hyperemia are acute. Chronic active hyperemia does not occur. So active hyperemia usually happens when the body needs more oxygen or blood in just a specific area. Active hyperemia can be observed when someone is exercising, when someone has fever, or it's just hot out. So hyperemia can be general or local. So acute general active hyperemia is the sudden increase of blood volume in the entire arterial system of an individual, while local can only observe in a specific local area like legs, stomach, or lungs. So next is passive hyperemia or congestion. This is an increased amount of blood flow in the venous side of a vascular system. This might due to the vascular lesion or injury. As we see in the illustration, the unoxygenated blood from the venous side are more when the congestion happen. So acute general passive hyperemia is an increased amount of blood in the veins. It is only temporary. While the acute local passive hyperemia only affects the specific area like foot, tail, kidney, and spleen. Now is chronic general passive hyperemia. Now from the word chronic, it can be happen in a long period of time. General passive hyperemia can affect a large area in the body. It then can affect the organs and tissues permanently. While chronic local passive hyperemia only affect specific areas. Now, hypostatic congestion. This is the accumulation of blood in the ventral portion of the body due to the influence of gravity. Usually, they only find this when the animal died due to the position of the accumulation of blood. Next is hemorrhage. Hemorrhage is defined as the escape of blood from a vessel. Now, hemorrhage can be categorized by size. Petechiae is a minute pinpoint. Now, purpura is an hemorrhage approximately 1 centimeter in size. Ecchymus is an hemorrhage 1 to 2 centimeters in size, and extravasation is an hemorrhage affecting a large area. Now, hemorrhage can be happen internally and externally. External hemorrhage can be observed in a traumatic wounds in the body of orifice. An internal hemorrhage can be observed through intensive diagnostics. Hemorrhages also have two types. Hemorrhage by resix. It is when there is a rupture or break in the blood vessel. While the hemorrhage by diapedis is when the blood leaves throughout an apparent intact vascular.
Hemostasis and thrombosis. Now, hemostasis means localized blood stop, where hemo means blood and stasis means stop, where combining these two is the arrest of blood loss from damaged blood cells or blood vessels. Now, keeping the blood natural thin, preventing it to become thrombotic, their endothelial cells secretes chemicals, nitric oxide and prostacyclin or PG 12, which naturally inhibits the platelets. It keeps the platelet inactive and prevents the platelet from being able to bind on endothelial lining. Now, next one is the protein, the heparin sulfate, which are natural anticoagulant. Now, this heparin sulfate binds to another protein, which are the antithrombin 3, that degrades clotting factor 2, 9, and 10. Those factors are inactivated by the antithrombin 3. Now, next is the protein thrombomodulin, which binds to another protein, which is the thrombin factor 2. And this thrombin attracts protein C and activates protein C, and protein C degrades factor 5 and 8 to be inhibited. Now, vascular spasm has three mechanisms. Whenever there's damage to a blood vessel lining, blood can leak out. We don't want the blood to leak out. If you start losing blood volume, it can lead to blood problems. So prevent blood loss from occurring. So we want to contract or constrict the blood vessels. By constricting the blood vessels, we decrease the amount of blood that is being lost. That's the vascular spasm. Now, causes the muscles to contract whenever smooth muscles are injured or endothelial cells. They secrete chemicals, which are the endothelin. They go to receptors in the smooth muscles and binds on them. That activates an intracellular mechanism will cause contraction, which is the vasospasm or vasoconstriction. Next is whenever a direct contact injury to the blood vessel wall, it actually causes direct injury to a smooth muscle. There is a protective mechanism in response to that, and it is called a myogenic mechanism. Next is whenever an inflammation you release, there's an inflammation here. Example, you release a specific type of inflammatory chemicals. Now, this chemical stimulates the receptors or the noise co-receptors that initiate the pain, and this pain reflex can cause vasoconstriction. Now, next is the plug formation. Protein produced by endothelial cells, which is the von Willebrand factor or VWF, this one here. Normally, platelets love to bind collagen. Now, this one is the platelets. Now, there is a specific receptor where platelets bind to von Willebrand factor. Now, these platelets granules activates and releases chemicals, which are the ADP thromboxane 2, that ADP here, this one, the ATB, yeah, ADP, and thromboxane 2 that stimulates and activates platelets and causes them to come from the site of injury. The platelet starts to aggregate the injury, or what we call the platelet aggregation. Platelet will form plug in the injury. Now, platelet one that binds with one Wilderman factor in the platelet is linking them together. Now next is the serotonin and thromboxane 2 that loves to bind to smooth muscles, and whenever they bind to smooth muscles, they cause contraction that leads to vasoconstriction. Next is the coagulation cascade. Now, phospholipid serine groups that are present in the platelets here. This is the platelets, and on the outer side of here, the phospholipid serine groups are present, and it creates negative charges. You know, our liver, it constantly making tons of clotting proteins, and these clotting proteins are normally circulating within the blood plasma, but they are kept inactive. Now, these walking protein proteins may interact here within phospholipid serine groups, which makes them inactive. Now, interacting with them will convert them into an active form enzyme, which is the zymogens. Now, these zymogens or factor 12 activates factor 11. Yeah, factor 12 activates factor 11, then factor 11 interacts with another factor, is factor 9 here, then with calcium will be activated, and factor 9 will interact with another protein, which is the factor 8. Factor 8 will interact with factor 9 and form a complex, but needs two more presence to happen. They need platelet factor 3 and calcium. Now, factor 10 will interact with the complex, this one, factor 8 and factor 9 interact with the complex to be active to factor number 10. Now, factor 5 will react to activated number. Now, this is factor 5 will react to activated factor 10 and platelet 3 and calcium. Then this will react to another protein called the prothrombin activator, this one. After activating, now activating this one, the thrombin or factor 2, it reacts two ways. There's a molecule fibrinogen, a plasma protein which are soluble, and factor 2 are thrombin polymerizer that starts linking them together. Now linking them together turns them into a molecule of fibrin, and this fibrin is insoluble in blood plasma. It's gonna help the blood to turn the blood into blood liquid, into jelly-like substance. That's the purpose of coagulation. We want it to be more jelly-like so it will slow down the blood flow beyond the injured area. Now, thrombin now reacts to another protein called factor 13, or this one, the fibrin stabilizing factor. Now, this protein is activated by thrombin but needs calcium. Now, this factor 13 will take this fibrin strand and cross-link them together. Now, the purpose of cross-linking this is to form a nice fibrin mesh. This one here, that will lay over to the platelets and prevent the platelet thrombus dislodging and going to another area, causing embolism. Here, this one. Now, next is the clot retraction and repair. Platelets have contract in them called myosin and actin. They pull the edges endothelial cells closer together. Example, there's a damaged cell here, and they will pull it together in here, bringing them closer. This secret chemical called platelet-derived growth factor comes down to smooth muscle. If you send the edges of the damaged endothelial cells closer together, now platelet construction secrete chemical platelet-derived control factor that comes down to smooth muscles if they are damaged. Now this platelet-derived growth factor triggers the mitosis or proliferation of the smooth muscle lining, and if there's a damage to the connective tissue, it's gonna cause a connective tissue patches to be formed, regenerate those collagen fibers that are damaged. Now there's also a vascular endothelial growth factor, which is a chemical secreted by platelet. Now this regenerates the endothelial lining. Now next is the thrombosis, meaning the pathological formation of hemostatic plaque within the vasculature in vivo. In the absence of bleeding, the formation of a clotted mass of blood within the vascular system. The mass is called thrombus, and the plural form of it is thrombi. A thrombus must be differentiated from a blood clot. A thrombus is formed by a complex process involving interaction of blood vessels, form elements of blood, and coagulation system. Now, here is the virtuous triad. Integrity of the endothelium is the most important factor. Injury to endothelial cells can also alter local blood flow and affect coagulability. The abnormal blood flows or stasis or turbulence can cause endothelial injury. The factors may act independently or may combine to promote thrombus formation. Now, this endothelial injury is the single most important factor and by itself can lead to thrombosis. It is particularly important in thrombus formation in the heart and arteries. Many factors can injure the endothelium. The most common are the mechanical forces, the cause constitutions, abrasions, lacerations, ruptures, and crushing injuries. Now, the alteration in normal blood flow. The rate of flow is extremely important in the formation of a thrombus. In normal blood flow, the large particles such as white cells and red cells occupy the central, the most rapidly moving axial stream. Next is the hypercoagulability. Usually plays a less significant role in thrombosis, but all the same is important factor. An increased tendency of thrombosis is associated with a variety of conditions such as following severe trauma, including fractures or burns, disseminated cancer, suppurative processes, especially suppurative pneumonia during late pregnancy and following delivery, and several others. Now, thrombus is the platelets accumulating on the endothelial surface produce a white or pale-colored mass at the site of injury. It gradually increases in size and may even completely obstruct the blood vessel, like this one. With slowing of the blood flow, formation of fibrin is facilitated. The platelets come in contact with the vessel wall, and this is turn enlarge the thrombus rapidly. Now, thrombi and embolus. Thrombi is the in rapidly moving arterial or cardiac circulation are composed largely of platelets and fibrin, whereas blood clot is composed primarily by fibrin. Now, embolus is an intravascular solid liquid or gas mass carried in a bloodstream. Most emboli are derived from thrombi. Take note, formation of a blood clot involves the blood clotting system. Now, clotting occurs when the blood is drawn into a test tube or when a blood vessel is cut. Clotting also occurs after death, which is known as postmortem clotting of blood. Now, the differentiation of postmortem clots from venous thrombi. Now, the red and clear jelly clots are those in which components of the blood are evenly distributed. This occurs when there is a rapid clotting of blood and its composition is normal. Now, the yellow or chicken fat clots are those in which components of the blood are not evenly distributed. The ventral position of the clot is red and contains erythrocytes, while the dorsal portion is yellow and it is composed of fibrin and plasma. These clots occur when erythrocytes do not remain in suspension and settle out. Now, these are the differences of thrombus and postmortem clot. Next is the classification of thrombi. They may vary in color, location, and composition. Now, first classification is according to the location within the blood vascular system. First is the cardiac thrombi. These are located in the heart and may be attached to the valves or vulvar thrombi or walls, which are the mural thrombi. Now, next is the arterial thrombi. These are located within the arteries and are usually firmly attached to the damaged arterial wall. Next is the venous thrombi. These are found in the veins. They are also known as phlebothrombosis and sometimes incorrectly as thrombophlebitis in the mistaken impression that inflammation of the vein is caused by the thrombi. Next is the capillary thrombi. These are located within the capillaries. They are mostly associated with the inflammation because the etiological effects agents easily injure the vascular endothelium. Next is the lymphatic thrombi. These are found in blood vessels and sinuses of lymph nodes and are composed of fibrin. Now, the second classification is the location within the heart or blood vessels. Now, mural thrombi are attached to the wall of the heart or blood vessel. They generally occur within the cardiac chambers and aorta. Next is the valvular thrombi, which are attached to the heart valves. Next is the lateral thrombi, which are attached to one side of a vessel wall. Next one is the occluding thrombi. They are attached to the entire circumference of the vessel. Next is the saddle thrombi. Sit on the bifurcation of blood vessels just as a saddle straddles the back of a horse. Up next is the canalized thrombi. Those thrombi in which new blood channels have been formed through the clot. These channels allow a partial restoration of the blood circulation. The channels are lined with the endothelium. Now, the third classification is according to the infectious agent. Now, first is the septic thrombi, which are those which contain bacteria. Next is the parasitic thrombi, those which contains parasites. And the third is the aseptic thrombi, those which do not contain bacteria or parasite. Now, the fourth classification according to color. A pale or white thrombus, white in color and composed entirely of platelets. It is observed in heart and blood vessels like aorta, carotid, and femoral arteries. Next is the red thrombus, red in color, composed of platelets, fibrin, erythrocytes, and leukocytes. The red color is due to erythrocytes trapped in the fibrin meshwork. A red thrombus is usually observed in veins. It should not be confused with a postmortem clot. Next is the mixed thrombus. Is composed both white and red thrombi and is the most common type. The white portion forms when the blood flow is rapid and the red portion when it's slow. Next is the laminated thrombus, which is the type of mixed thrombus composed of alternate thin layers of paler platelets mixed with some fibrin separated by darker layers containing more red cells. The fate of the thrombus. The first one is the propagation. The thrombus may accumulate more platelets and fibrin or propagate by its enlargement and eventually causes obstruction of a vessel. Next is the emboli formation. The thrombus may give rise to emboli that are carried away from their sites of origin. These emboli are dangerous because they lodge in smaller vessels and cause infarction. Now, infarction means heart attack. Abscission. Abscissation is the abscesses appear in thrombi when pyogenic bacteria are present. Next is dissolution. A thrombi may be removed by fibrinolytic activity. Next is the organization and recanalization. Thrombi may cause inflammation and fibrosis and may eventually become a recanalized or established vascular flow. Enzymes derived from leukocytes and platelets begin to digest the thrombus. At the same time, fibroblasts and capillaries proliferate and invade the base of the thrombus. Next is the calcification. Since a thrombus contains degenerating and necrotic tissues, it may go under dystrophic calcification. That's all.
Okay, so embolism and infarction. First, we have embolism. What is embolism? Embolism is the process of formation of an embolus. Now, what is an embolus? Okay, an embolus is a detached intravascular solid, liquid, and gaseous mass carried by the blood to a site away from its point of origin. Okay, so don't be confused with the thrombus and embolus. Okay, so as we recall, thrombus is a solid mass formed from the constituents of the blood, while embolus is a solid, liquid, and gas. It can be thrombus, which is a solid mass. It can be clumps of bacteria. It can be fat and more, which will be discussed later on. Okay, so to discuss this further, we have here a diagram. Here on the left side, we have the deep vein. Let's say deep vein from limb, okay, lower limb. And we can see here a solid mass, which I named thrombus. Thrombus, why? Because thrombus is the most common cause of embolism. Okay, so this thrombus happens to detach from its point of origin, going to the flow of blood and to the caudal vena cava, entering the right atrium, down to the right ventricle, and into the pulmonary artery. From there, pulmonary artery, the embolus happen to lodge, and if that embolus lodged in the pulmonary artery, it is now called pulmonary embolism. Okay, and the whole process from the detachment of the embolus going to the right part of the heart into the pulmonary artery and get lodged is called embolism. Next is location of emboli. We have here venous embolism. Okay, venous embolism is an event where an embolus originates from the deep veins of the leg, which is very common in humans. And also keep in mind that an embolus is rarely get lodged into a vein. Okay, why? Because the flow of blood in the vein is always into a blood vessel of increasing diameter. Okay, increasing diameter. That is why the flow of blood together with an embolus or thrombi is not always prevented. Next, we have arterial embolism. On the other hand, it is an event where an embolus originates from the heart, which is always occurs in animals. Okay, arterial embolism, on the other hand, is the embolus always get lodged on the artery. Why? Because the flow of blood is always into a blood vessel of decreasing diameter. Okay, so it gets narrower in the artery. That is why always lodge in the artery. Okay. Next is pulmonary embolism. Okay. Pulmonary embolism was uh, the first one I have discussed to you. Okay. Okay. So we have paradoxical embolism is an event where an embolus originating from a venous thrombi, instead of getting caught in the lungs, may pass through an intracardial defect and gain access to the systemic circulation. Okay, so let's say an intracardial defect is a patent foramen ovale. Okay, as we recall, uh, during embryonic development, a foramen ovale is a connection between two atria of the heart so that blood can bypass the lungs. Okay, normally this foramen ovale closes at birth, right? And if it does not close, then it is now called patent foramen ovale, okay, which may remain patent for the whole life. And the main complication of this is embolism, no? Paradoxical embolism. Okay, let me show you a diagram of the heart. Okay, it shows there the patent foramen ovale, right atrium, the right ventricle, the left atrium, and the left ventricle. Okay, let's say for example, an embolus from the deep vein happens to detach from its point of origin, go with the flow of blood and into the caudal vena cava, entering the right atrium, and from there, instead of going down to the right ventricle and into the pulmonary artery, the embolus will pass through the uh, foramen ovale going to the left atrium. Okay, from the left atrium going down to the left ventricle and into the aorta. From the aorta into the different uh, branches of the artery, which is abnormal, no? Which may cause a stroke. Next, we have common emboli found in arterial circulation. We have here number one, thrombi. Okay, so as I have mentioned earlier, this is the most common cause of embolism, which also gave rise to the term thromboembolism. Okay, number two is bacteria. Okay, these emboli are frequently observed in many diseases and occur as clumps of bacteria. No? And number three, parasites. A good example of this is canine heartworm. And number four, neoplasm. These are clumps of tumor cells. Growing tumor cells invade arteries and also lymph nodes and can cause embolism. Okay, number five is fibrin. Okay, it forms fibrous mesh that impedes the flow of blood. Okay, number six is fat emboli. This occur when there is a fracture in the long bones, which will cause the release of fatty marrow that includes fat globules inside the circulation. Okay. Next is clumps of normal body cells. Okay, so this appears in circulation when tissues and organs have been injured. Okay. Next is air and gas emboli. Okay, this happens when air bubbles enter into the venous or arterial circulation, obstructs vascular circulation, and damage tissues. Okay, next, infarction. Okay, what is infarction? An infarction is the process of forming an infarct. Then what is an infarct? An infarct is an area of ischemic necrosis caused by occlusion of either arterial blood supply or rarely the venous drainage in a particular tissue. Okay, so let me give you an example of this event of infarction. But okay, first let us define what is an ischemic necrosis mean. Okay, so uh, an ischemic necrosis or ischemia, as we can recall, ischemia is an event of a reduced blood supply. Okay, and necrosis means cell death. So ischemic necrosis means a cell death caused by diminished or reduced blood supply. Okay, and that area where an ischemic necrosis is present is called infarct. Okay, so we have here a diagram of a blood vessel. Okay, remember that the most common causes of infarction are thrombi and emboli. Okay, let's say as you can notice, there is a solid mass in in this blood vessel. Okay, let's say for example this solid mass is an emboli. Okay, so this at first this solid mass will cause reduced blood supply in the area of blood vessel, and then eventually, because of the stress caused by this solid mass in this blood vessel, it will trigger the formation of a blood clot. And when a blood clot is formed, also in this area, an occlusion of this blood vessel will happen, okay, which will result in infarction. So next we have types of infarction. Okay, number one is white or pale infarct. This usually occur in solid organs like kidney and spleen. And the idea behind the white color is that the solidity of the organ limits the amount of hemorrhage into the area of ischemic necrosis. Okay, and number two, red or hemorrhagic infarct. This can be developed in loose and spongy tissues or organs. For example, lungs. Okay, because loose and spongy organs, blood is allowed to accumulate in the zone of infarction, which will cause red infarct. Next, we have factors that influence the development of infarct. We have number one, the nature of blood supply. Okay, the most important factor that to determine whether an occlusion of a blood vessel will cause damage is whether an organ is supplied by a double or single artery. Okay, so say for example in the lungs where double blood supply from pulmonary vein and bronchial artery is present. Okay, so in this organ, the occlusion of either of the two blood supply may be without effect. Why? Okay, so let me explain through this diagram, the diagram of the lungs showing the bronchial artery and the pulmonary vein. Okay, so let's say for example, one of these blood supply has been occluded. Let's say for example, the bronchial artery has been occluded, then this may result into ischemia. Okay, however, remember that there is still another blood supply, which is the pulmonary vein. Okay, so this blood supply coming from the pulmonary vein somehow prevents the infarction to occur. Okay. On the other hand, some organs like kidney and spleen have only a single arterial blood supply. So occlusion of the major branch of the arterial supply is followed by ischemic necrosis. Okay, next we have rate of development of occlusion. Okay, slowly developing occlusion is less likely to cause infarction. Okay, so this is because they provide time for the development of alternative pathways of flow and anastomotic bypass channels to develop. Okay, number three is vulnerability to hypoxemia. Okay, tissues of the body differ widely uh, in their susceptibility to ischemic hypoxia. Okay, say for example, uh, the neurons. Okay, in neurons, irreversible damage can happen after only 2 to 3 minutes of ischemia, while myocardial cells, on the other hand, is much hardier and will die after 20 to 30 minutes of ischemia. Okay. A number four is oxygen content of blood. Okay. Anemic patient cannot tolerate the arterial insufficiency, and occlusion of the blood vessel may lead to infarction. Okay. Unlike to a normal patient, it might be without effect. Okay. So that's all for embolism and infarction.
For the next hemodynamic disorders, we will be discussing about edema and shock. So first, let's discuss edema. Edema is a condition characterized by an excessive accumulation of fluid in the interstitial tissue spaces or body cavities. Edema is swelling that is caused by fluid trapped in your body tissues. Edema happens most often in the feet, ankles, and legs, but can happen to other parts of the body such as the face, hands, and abdomen. It can also involve the entire body. So we have what we call cell swelling, which is an acute reversible change resulting as a response to non-lethal injuries. It is an intracytoplasmic accumulation of water due to incapability of the cells to maintain the ionic and fluid hemostasis. So it can be local or diffuse and can affect the whole organ. In cell swelling at gross examination, the affected organ is enlarged, pale, and soft. Microscopically, the cells are enlarged with a clear cytoplasm due to the presence of small clear or pale vacuoles with indistinct shape and limits, and a normal nucleus in central position. Um, Blood capillaries are also compressed, explaining the organ's pallor. So, edema can be localized or generalized. We have here the examples of a localized edema. First, we have the lung edema or the hydrothorax, which is the accumulation of fluid in the thoracic cavity or the pleural cavity. Um, for the next example, we have ascites or the hydroperitoneum. So this is the excess fluid buildup in the belly or the abdomen because of the pressure from tumors. Hydroperitoneum is also the collection of edema fluid in the peritoneal cavity. For the next one, we have pericardial effusion, and or we also call this the hydropericardium, and this is the build-up of extra fluid in the space around the heart. So if too much fluid builds up, it can put pressure on the heart, and this can prevent it from pumping normally. For the next example, we have the hydrocephalus. Hydrocephalus is an abnormal buildup of fluid in the ventricles or the cavities deep within the brain. This excess fluid causes the ventricles to widen, putting pressure on the brain's tissues. And next we have hydrocele, and this refers to the local accumulation of fluid in the tunica vaginalis of the testicles. Oh, um, before that, we also have what we call the generalized edema, which so this edema involves the entire body. It is called anascara, and anascara is severe and causes swelling of the subcutaneous tissues. So if the edema fluid is non-inflammatory, it is referred to as a transudate. It is low in protein and other colloids with a specific gravity below 1.012. In contrast, inflammatory edema, due to increased vascular permeability, is protein-rich and therefore has a high specific gravity, usually over 1.020. And this inflammatory fluid is called an exudate. So now let's discuss the pathogenesis of edema. So edema is the result of an increase in the forces that tend to move fluids from the intravascular compartment into the interstitial tissue spaces. The volume of each compartment is maintained within narrow limits in health, but there is constant interchange between them. The exchange between intravascular and interstitial compartment is governed by Starling's forces. So according to the Starling's forces or the Starling's hypothesis, the normal fluid balance is maintained by two opposing sets of forces, namely vascular hydrostatic pressure and plasma osmotic pressure. So fluid moves from intravascular to the interstitial compartment at the arteriolar end of the microcirculation, largely under the influence of the hydrostatic pressure. It returns to the intravascular compartment at the venular end, mainly because of the osmotic pressure. The balance of these factors is such that there is only a small excess of fluid in the interstitial tissue spaces, but this fluid is normally drained off through the lymphatics, and so there is no edema that occurs. Thus, the volume of interstitial fluid depends on the hydrostatic pressure of the blood at the arterial end of the capillary, the level of the plasma proteins, and the adequacy of the lymphatic drainage. So the following illustration will show the relationship of hydrostatic and osmotic pressure in the exchange of fluids through vessel walls in a normal resting leg. So we have here this illustration. It shows the normal flow of fluid. So fluid leaves at the arterial end of the capillary bed because 45 millimeter of hydrostatic pressure is overcoming the 30 millimeter osmotic pressure of blood plasma, and fluid is being forced into the tissues at the rate of 15 mmHg. At the venular end of the capillary, hydrostatic pressure of 15 mmHg cannot overcome 30 millimeter osmotic pressure of blood, and fluid flows from the interstitial tissue spaces into the venular end of the capillary at the rate of 15 mmHg. Since it is entering the tissue at the rate of 15 mmHg and leaving at the same rate, there is a continuous circulation and no accumulation of fluid occurs in the interstitial spaces. However, not all the fluids in the interstitial spaces returns to the venules. Some are drained off through the lymphatics. So, when will edema occur? So, edema will occur when there is an increase in intravascular hydrostatic pressure. Intravascular hydrostatic pressure is the main force that determines fluid leaving out of the capillaries. An increase in intravascular hydrostatic pressure will result in more fluid leaving out of the capillaries going into the interstitial spaces. Edema will also occur when there is a fall in colloid osmotic pressure of the plasma. This causes water and solutes escaping into the interstitial space into the capillaries. And for the next one, edema will occur when there is impairment in the flow of blood. So poor blood circulation usually results in the accumulation of fluid in certain parts of the body, and this usually happens in the legs. So now we will be discussing about the causes of edema. For the first cause, we have increased hydrostatic pressure. So we have here this illustration. So the increased hydrostatic pressure is usually a result of impaired venous return. Though not too common in animals, it is usually common in humans. As we remember from the latter part of the discussion, the normal flow of fluid into the tissues is at 15 mmHg and vice versa. In a person with a normal hydrostatic pressure and osmotic pressure at the arterial end of the capillaries, at the rate at which fluid flows into the tissues is 15 mmHg. Same goes with the normal osmotic pressure and hydrostatic pressure at the venular end, where the fluid flows in the veins at 15 mmHg. Thus, there is normal return of fluids. In a case that the hydrostatic pressure in the venous end is high, the rate at which the fluid flows into the veins gets lower, impairing the flow and causing accumulation of fluid into the tissues. So for the next cause of edema, we have here reduced plasma osmotic pressure. So this is the most common cause of edema in humans and animals. In domestic animals, it is the most common cause of edema than increased hydrostatic pressure. So reduced plasma osmotic pressure is a result of excessive loss or reduced synthesis of serum albumin. So we have here hypoproteinemia, which is the low protein levels in the blood. And this may occur as a result of heavy infestation of trichostrongylls or stomach worms in sheep and cattle. The daily loss of blood without adequate replacement due to these parasites causes parasitic edema. So we also have here a renal injury. So renal injury also causes loss of blood protein, which is common in humans but not in animals because nephrotic syndrome does not occur in animals. Edema as a result of kidney disease is called renal edema. We also have cirrhosis, which is a form of advanced liver disease and can also lead to hypoproteinemia because of decreased synthesis of plasma proteins in the liver. During periods where there is inadequate protein in the diet, such as starvation or malnutrition, the liver is unable to produce adequate amount of protein, resulting in a decrease in the osmotic pressure of the plasma, which leads to edema. The accumulation of fluid into the interstitial spaces or body cavities is explained as follows. Comparing to edema caused by increased hydrostatic pressure with only 5 mmHg rate of fluid accumulation in the tissues, the reduced edema osmotic pressure causes fluid to accumulate in the tissues at the rate of 20 mmHg, making it more severe. For the next cause, we have lymphatic obstruction. Um, Lymphatic obstruction is the interference with the lymphatic drainage, leading to the accumulation of interstitial fluid, which can lead to local edema and may result from inflammatory or neoplastic obstruction, usually tumors or cysts. So we have here an example, which is elephantitis. This is the extreme edema of the lower limbs. For the next example, we have lymphedema. So this is a form of local edema where the fluid leaking from the blood vessels nor the proteins within the interstitial fluid that are supposed to be drained to the lymphatic system gets stuck due to lymphatic obstruction. This results to the reduction of net effective osmotic pressure of the blood. For the fourth cause of edema, we have sodium and water retention. So this is So sodium and water retention is the result of the failure of the body to excrete sodium in the urine, which causes water retention, leading to generalized edema. It usually happens to people with congestive heart failure, nephrosis and nephritis, and acute renal failure. So for the significance and results, edema disappears if the cause is removed. Edema can be fatal in the brain and lungs. Subcutaneous edema and edema of other viscera, on the other hand, are usually of little functional significance. Edema in animals could be fatal, especially to those who are gestating. Understanding the process of edema formation and its implication to the animals makes it easier to find the best way to eliminate the excess fluid from the animal's body. Due to that, avoidance of edema-causing factors can also help the animals live a better and more comfortable life. So now we will be discussing about shock. So shock is a critical condition caused by a sudden drop in blood flow through the body. This leads to abnormally low blood pressure or hypotension. Lack of blood flow means the cells and organs do not get enough oxygen and nutrients to function properly. This can lead to damage of organs. Shock requires immediate treatment and it can get worse very quickly. Now we go to the etiology of shock. Shock, also called intravascular collapse, may develop following any serious attack on the body's hemostasis. Shock may be a result of trauma, heat stroke, blood loss, an allergic reaction, severe infection, poisoning, severe burns, or other causes. Shock associated with crushing injuries, especially those that invade the chest and abdomen, are frequently observed in dogs injured by cars or other automobiles. Profuse hemorrhage and burns are common causes of shock in domestic animals. So we have some pathophysiological types of shock. We have four of them, and the first one that we will be discussing is hypovolemic shock. So hypovolemic shock is an emergency condition caused by hemorrhage, fluid loss from the extensive skin burns, exudation from large traumatic wounds, diarrhea, and vomiting. The next one is the cardiogenic or cardiac shock. This one is a life-threatening condition in which your heart suddenly can't pump enough blood to meet your body's needs. The condition is often caused by a severe heart attack, but not everyone who has a heart attack has cardiogenic shock. Cardiogenic shock is actually rare, and it's often deadly if not treated immediately. But when treated immediately, about half the people who develop the condition survive. For the next one, we have septic or endotoxic shock. And this is a life-threatening condition that happens when your blood pressure drops to a very dangerous level after an infection. Any type of bacteria can cause the infection. At first, the infection can lead to a reaction called sepsis. This begins with weakness, chills, and a rapid heart rate. When it is left untreated, the toxins produced by the bacteria can cause damage to the small blood vessels, causing them to leak fluid into the surrounding tissues. This can affect the heart's ability to pump blood to the organs, lowering blood pressure. And for the fourth one, we have neurogenic shock. So neurogenic shock occurs when blood vessels stop working properly and don't push enough blood through the body. In this case, there is no blood loss, but the blood present in the body does not circulate well, causing it to pull in the blood vessels, leading to a significant drop of blood pressure. So now we will go to the different stages of shock. So shock passes through three general stages. For the first stage, we have the early non-progressive stage. During this stage, various neurohumoral mechanisms maintain cardiac output and blood pressure. It causes rapid heartbeats, peripheral vasoconstriction, and renal conservation of fluid. Cutaneous constriction is the one responsible for the coolness and paleness in the skin of people who are in shock. So the second stage is the progressive stage. So if the underlying causes get worse, the shock goes into the progressive phase, and there will be a widespread tissue hypoxia, the condition where there is not enough oxygen for the tissue. Because of persistent oxygen deficiency, anaerobic glycolysis happens, and there will be an overproduction of lactic acid. This causes pH levels in the tissues to drop and blunts the vasomotor response. This event causes the arterioles to dilate, causing blood to pool in the microcirculation. Due to widespread tissue hypoxia, the vital organs start to fail. Clinical characteristics of this stage include abnormally rapid respirations and marked reduction in urinary output. This stage registers a marked deterioration in the condition of the patient. For the third stage, we have the irreversible stage. During this stage, Treatment can no longer stop the deteriorating condition of the patient. There will be a progressive reduction in the cardiac output, progressive fall in blood pressure. The reduced blood flow to the brain, heart, and kidneys lead to hypoxic cell death, resulting in coma, renal failure, uremia, and death. So, what are the symptoms of shock? It says here that the animal will feel cold, weak, depressed, lethargic, anxious, and worried. The body temperature is subnormal and skin cold. There will be a tremendous fall in the blood pressure, and the respiration is shallow and irregular. Blood pressure is also low, pulse is rapid, and the heart rate is very rapid. The animal becomes unconscious and finally dies from circulatory failure. The animal recovers with appropriate therapeutic measures that are focused on restoring blood volume, increasing cardiac output, and improving blood pressure. That happens if the blood volume cannot be restored and adequate circulation is not maintained.